I'd like to thank everyone for coming early. We're going to be doing a presentation from Columbia Memorial Health. So I'd like to introduce Dorothy Burchill, who's the Chief Executive Officer.
That's right. Very loud. Thanks, Mr. Mural. I really appreciate it. Can everyone hear me okay? Is it too loud? I'll step back a little bit. Pleasure to be here this evening. Dorothy Burchill, I'm the President and CEO of Columbia Memorial Health. My background, I'm a doctorally prepared nurse practitioner, worked in heart surgery and critical care for over 20 years in Western New York, and subsequently moved to the capital region, 2006. I then worked at Westchester Medical Center for a couple of years in heart surgery, really to understand cardiac assist devices and heart failure management, so ventricular assist devices. And then came back to Albany and was the Director of Cardiac Surgery Services and then the Vice President of Cardiovascular Services at St. Peter's Health Partners. Joined Columbia Memorial Health in 2019, and right behind me came the pandemic. So we were pivoting quite a bit. And then became the CEO, ascended into the role 3 years ago after J.P. Halen's retirement. So it's been a pleasure for the last 3 years to lead with a great team at the hospital. And I want to introduce Mr. Brian Mahoney, who's our Chief Financial Officer, who's great at what he does. We're partners in crime because we have to be. When you are managing a rural community hospital, it's important to have the right people with you. And again, my team is fantastic. I want to introduce Mr. Michael Irwin, who's back there. Mr. Irwin is on our board and also on the Albany Med Health System board and the mayor board of the Albany Med Health System, and is a fantastic support. He has many years. He was with the Citigroup for a number of years, providing the health economics. So he really knows this business well. So thank you. So I don't know if the clicker works. I'll start there. See, so I start with this slide because there was unfortunately a letter that was emailed to the Democratic Party that Columbia was closing and that there would be layoffs. So I wanted to be very clear that Columbia Memorial Health is not closing. Not the hospital, not the emergency room, not the 37 outpatient centers that we provide care at. We are not planning any layoffs. We are going to continue to grow. In fact, from a full-time equivalent and employee perspective, we need to continue recruiting. In fact, I received an email this morning from the Chief Operating Officer at Planned Parenthood, and she said, hey, if you have any extra people, send them my way. I hear you're laying off. And I said, we are not laying off. We, in fact, need folks, but I'm happy to work with you if you need help with anything. So this slide is really a high-level slide, but it really introduces our system. So Columbia Memorial Health joined the Albany Med Health System in 2016. We started that process of affiliating in 2015. And the reason why my predecessors did that was because rural community hospitals across the nation were struggling financially or closing. They also did it from a clinical integration perspective. Columbia Memorial Health provides great services, but they are truly primary and secondary care services. We do not provide tertiary care at Columbia, but we provide a really nice footprint. Again, as I said, 37 outpatient sites, 18 of them primary sites, and many of them general surgery, orthopedic surgery, mental health services, gynecologic surgery and services, women's health services, breast cancer services, diagnostic imaging centers, as well as outpatient rapid care centers, or also known as urgent cares. And those are really important to the communities. And then we have this large hospital, a hospital that is not full, has really, quite frankly, never been full. We have 22 inpatient psychiatry beds. We have a great footprint on the outpatient side in terms of psychiatry. Why we partnered again with Albany Med was to make sure that we can advance patients' care. So we believe that healthcare is local, but we can only provide so much care locally. And those patients requiring a higher level of cardiac care, like cardiac catheterization and open heart surgery, or cancer care or cancer surgery is done at Albany Med. Albany Medical Center is providing almost a $50 million investment in us. So $25 million at Green Medical Arts right over the bridge. Green Medical Arts, just as a reminder, was once a hospital. It was a hospital in the 1990s. It was in fact closed by New York State. There were quality issues, there were financial issues at the time. Columbia Memorial Hospital at the time picked it up, and we were able to move the beds from the Greene County Hospital over, which didn't mean that in fact we had those physical beds. It was just on the operating certificate of the hospital. So when you read in the newspapers that there are 192 beds in the hospital, there in fact are not 192 beds. It means that we're certified to operate beds if we needed to move up and take those patients, but we've never needed those beds. We have developed a strategic plan and a shared process to transform with the Albany Medical Health System. The financial overview, I'll start, and I'm going to actually ask Brian to expound on what I'm going to say. But pre-pandemic, Columbia Memorial Health performed at a break-even operating margin. And we continued to expand even though we were a break-even margin. As a non-for-profit hospital, we do need to make a positive, we need to make money to be able to reinvest in our community. But post-pandemic, we saw a significant drop-off in the volume of patients coming to the hospital, not the outpatient centers, those are very busy, but the inpatient side really dropped off. So we were at about 77 during the pandemic. We dropped to about 45 to 50 inpatient medical surgical patients. And then our psychiatry unit ranges anywhere, it was at the time anywhere between 17 and 22 patients. The temporary, so cumulatively, $78 million deficit, and temporary staffing costs exceeded $25 million annually. And that was again because it was difficult to staff during the pandemic. We saw the Great Resignation, those individuals that were nurses for many years, in fact, had retired and or resigned because they were really afraid of caring for those patients. It was a very difficult time for healthcare, and quite frankly continues to be. At the same time, the inflationary labor and supply costs had significantly outpaced the reimbursement increases from Medicare, Medicaid, and commercial payers. And our inpatient payer mix, of the hospital side only, this is not including the outpatient side, is 89% government pay. So that's Medicare and Medicaid. And the reimbursement does not fully cover the cost of the care that we provide. A strong balance sheet prior to those years, prior to the pandemic, enabled us to continue the care that we provided along with government support. So we applied for a number of grants through New York State Department of Health, and thank goodness for those. But we found that government support was inadequate, and then even with cash flow relief from the Albany Medical Center, the deficits were unsustainable. And so we developed a multi-pronged approach to caring for our communities. That multi-pronged approach included Green Medical Arts and developing a surgical center. So really developing and bringing back care into Greene County. So again, as I said earlier, that hospital closed. And now we said, wait a minute, let's bring back surgery. And if you read anything in healthcare, the majority of what's moving is to ambulatory outpatient centers. So surgeries are moving. Orthopedics, 90% of what's done orthopedically can be done in an outpatient center and send you home the same day. Your hip replacement, your knee replacement. So we're also advancing cardiac care in that area, and that's in Greene County. And we know that this will continue to bring our patients back and reduce the out-migration of patients that are leaving Greene County because the services have left Greene County. So when you look at this map, star on the map, Columbia and Greene counties are served by Columbia Memorial Hospital. That one star is Columbia Memorial Hospital and the healthcare system that the care centers that we provide over the two counties. All of the other red stars are everywhere to the north and everywhere to the south. And again, you can see an area where it's very red, and that's heading into New York City and Westchester County. I think I'll bring you up afterwards and we can do that. And so we'll go through it, and then I'm going to answer questions, especially around the finances, because I do think you'll have a few. So again, the three-pronged approach was bolster inpatient behavioral health services at Columbia Memorial Health. We wrote a grant, and we received a $5 million grant to advance mental health services at Columbia Memorial. We are developing and building a 12-bed geropsychiatry unit at this hospital. It's necessary, and we know that that is an area of growth of this vulnerable population that we need to serve. The ambulatory surgical center that I outlined previously in Greene County at Catskill. And then the hospital redesignation is something we must do, and I'll explain why. Just to expand upon the inpatient behavioral health, again, awarded the $5 million, one unit dedicated to geropsychiatry. We're seeing a number of these patients advance and require advanced care. So we'll have that medical portion of caring for these patients and the psychiatry. We applied for the certificate of need in April of this year. We're still waiting to hear from New York State Department of Health. You're probably curious. We received the $5 million grant. We've applied for the CON. We're still waiting for the state. And in fact, the state has said, are you going to spend our money? And we say, yes, we will, but we need to be approved. So it's interesting. Greene Medical Arts, accessible to Columbia and Greene counties, moving the patients that can be done in an outpatient side from Hudson to there, keeping the surgery here on this site. But the popularity of same-day destination sites for both patients and providers is really key. Leveraging the grant that we received 2 years ago from New York State Department of Health, which was $5 million, and reinvesting in Greene County. And it will be the only one of its kind in the Mid-Hudson Valley. And the construction has started. And I was just over there today, and it looks fantastic. So we should be finished that construction by January of next year. And we will, I'm sorry, 2027. And we will then open that up for business and start that surgery there. Critical access. So the Critical Access Hospital designation was established in 1997 by the Balanced Budget Act to really address the closure of hundreds of rural hospitals. This was happening across the nation. It continues to happen. In fact, New York State Department of New York State has greater than 10 hospitals that are nearing closure. So we don't want to close. So we need to have a different option. This is the option for us. The Critical Access Hospital is a federally designated cost-based reimbursement program that's eligible for Medicare and Medicaid services. And the purpose of the Critical Access designation is to ensure that people enrolled in Medicare and Medicaid have access to healthcare services in rural areas, and they are certainly rural. Each Critical Access hospital must comply with the following conditions. They must be located in a rural area. They must offer 24/7 emergency services. And the inpatient limit is 25 beds. So you need to operate at 25 beds. You also have 10 swing beds, so that gets you to 35. You'll ask what's happening with psychiatry. Well, that is going to be a separate licensure through the New York State Department of Health called an Article 31. So it stays within the campus, stays on the campus, and we provide mental health services plus the 25-bed medical surgical care, and you can continue to do surgery. And those patients, just for your awareness, over 80% of the surgery we do currently is done as day surgery, so patients go home. So it only makes good sense. The average length of stay, however, is about 4 days, and we're around 5 today. We have, as I said before, 45 to 50 patients in the hospital. And when you look at this slide, you'll see that, again, that 192 certified inpatient beds, that's really a fallacy. That is not true. Those were beds that were brought over on the operating certificate from Greene County. Our inpatient census is 40 to 50. Our proposed bed change is 25 certified inpatient beds, 35 behavioral beds, to give us a total of 60. So in fact, at the end of the day, when we carry out that strategy, we'll have more beds. We'll have 60 total beds. The critical access hospital receives a higher reimbursement rate, which again allows us to reinvest in our hospital. And in doing that, we'll be able to bring other net new services to the communities that we serve. Better allocating resources will enable us to provide care to our patients for the things they need and remain viable and sustainable for the future for the community that we're serving. So we're doing this so we don't close. The United States nationally has 1,337 critical access hospitals. Many hospitals over the last 3 years have closed in rural areas. This is what we're trying not to do. This is our plan. There are 17 critical access hospitals in New York State. Ellenville is close to us. Margaretville is another. In speaking with those chief executive officers also in Berkshire County, Fairview, in Great Barrington, and North Adams was just opened in North Adams. And again, speaking with the CEOs of these hospitals, all of them said, we were on the brink of closure. We applied for critical access. We're now successful in our communities. We're bringing in great dollars, and we're able to refund what we're doing for our hospital setting and bring in new services. What happened was not the planful process I wanted to happen. So we hired a group called the SACS Policy Group out of New York City. In order to apply for a critical access hospital, there's a process. The process is you complete a CON application with New York State Department of Health. You complete a closure plan whereby you close the beds that you're not using, vacant today. And that closure plan describes how you're going to utilize those beds in the future and or what your plan is around the operations. And then the third thing is something called a health equity impact assessment. And that's why 3 weeks ago, I started in front of our staff. Those are the #1 people. I'm obligated to my employees to let them know what we're planning, what we're thinking, our physician staff, and then our constituents in the communities. The SACS Policy Group allowed us to have one-on-one meetings, which many, some in this room were involved with, the community town hall, and then other subsequent groups. It went a little haywire when the letter was sent out, and it caused a lot of consternation from our staff and the local communities, which unfortunately shouldn't have happened because we did have a plan. We had a plan. We, in fact, had a plan to reach out to all of you, but because it was taken off the rails, we had to pivot and made the decision to have a town hall immediately and invite those. Anyone was invited, and then we had folks online. We had 170 individuals in the room and over 100 people on the telephone listening. I think after that, and many interviews I did with local media and newspapers, I was able to at least, I think, allay people's fears to say, #1, we're not closing. #2, this is a planned approach. #3, we'd like to become a critical access hospital. It might take 6 months to 2 years, but this is what we need to do to provide to the regulators, which is CMS and New York State Department of Health, to get to where we need to get to. We also sent out 5,000 surveys, in fact, almost 10,000 surveys at this point, to our local residents and patients. And quite frankly, the 2 themes that have come back to me are adequate communication, transportation. Is EMS supporting this? And I have to write a mitigation plan and provide it to New York State Department of Health so that I can speak to all of these areas. I'm going to leave it there, and I'm going to ask Brian to come up, and you have something that's just come out. It's a fiscal survey report that I'd like Brian to speak to, because he's a master at what he does, but also you all have to know what's happening in healthcare today, and I thought this report was fantastic. So I'll have Brian come up, and then we'll take questions. Thank you.
Thank you, Dorothy. So Brian Mahoney, I've been with CMH for 15 years. 10 as CFO. One thing Dorothy has heard me say consistently is, in the business of healthcare, the last thing we want is to make it about the business. Unfortunately, through some of the things that you heard from Dorothy, we are talking about business-related matters as a mechanism to continue to offer services in the community and the expansive services that we offer, of which I'm sure you alluded to, mostly outpatient at this point. What we shared with you is just a simple one-pager that frankly didn't plan on, came out today. It speaks to some of the forthcoming stuff with changes to essential plan insurance. That's what they refer to when they talk about impact of the big beautiful bill. I'm not going to speak to that. I think this did a nice job highlighting in a very summarized fashion the financial challenges most hospitals in New York are facing, in particular upstate. This paper came from a joint report by all of the New York State Hospital Associations. Iroquois is our Upstate Hospital Association, Greater New York is the New York City Downstate Hospital Association, Suburban is over Western New York, and Hades, of course, is statewide. So collaboratively, they're attempting to call out that among all the financial challenges we're already incurring, the forthcoming challenges are just going to layer on top of what we experience by changing people's ability to get coverage. The last point I'll leave you with, just in reference to the one financial slide that Dorothy shared, which with intention is just one slide out of everything else we're trying and hoping to talk about, is CMH in my time, pre-pandemic, was a break-even institution. We had profitable years, we had challenging years, but we were continuously reinvesting in brick and mortar and advanced technology, which is not a cheap investment to continue to make in a building that was built however many years ago. We've all seen what the hospital looks like. You can imagine some of those challenges. Post-pandemic, there's been a few different levers I want to call out that have changed the financial equation for so many rural community hospitals. One is, as Dorothy already mentioned, a decreasing inpatient census. At the hospital, absent anything else we do, on the outpatient side, you need about 100 patients to break even because of the cost of staffing at 24/7, radiology, lab, support services, and housekeeping, et cetera. You need all those people, regardless of if you have 40 or if you have 100. But because you only get paid when somebody gets discharged, you need 100 to be able to cover all of those costs. So that is calculation that over the years has gotten away from us by way of the lowering census. We were 77, I think we said it was, when we hit the pandemic, below that threshold, and now, as Dorothy's mentioned, we're, let's just say 40 to 50 on any given day. So you can see where the hospital is becoming a big part of the financial challenge itself. However, our commitment is to do everything we can to maintain 24/7 emergency services, inpatient care, continue the outpatient footprint that we have, and find a mechanism to reinvest in the organization. We've all heard and seen on the slide the increasing cost of labor. We were competing with $18 to $20 an hour at Stewart's as well. Our union contract has been publicized over the years. So while our revenue profile is decreasing, our cost of labor is going up. That and inflation in our supplies and drug costs, everything else. So those are the big bucket challenges that have happened to us post-pandemic that have found us in this position. A way to try to change the economic equation is the critical access hospital, specific to the way the hospital operates, that pays us our cost. There's a recognition with the structure of critical access hospital that at 25 beds, you could never cover the overhead. So in order to maintain and preserve services, we will fund the cost-based profile, which is what we'll consume. I'll stop there. Again, never want to try to make it about the business of healthcare, but those are just a couple comments I'll offer and then answer any questions.
I have two questions. So first, thank you so much. Makes a lot of sense.
Thank you.
It's too bad that we don't have universal healthcare, so we have to talk about these things and look at it from a money perspective versus just a healthcare perspective, but here we are. So to stay under the number of beds, I'm hearing that we're about 40 to 50 now. We have to go down to 25 plus the 35 for mental health. And to keep the average stay length under 4 days, I heard you say the average stay now is 5. Do we transfer to Albany Med? Is that where
That's a great question. So I wanted to get into that, and I want to be very, very prescriptive with this. Out of those 45 to 50 patients, there are 10 patients that have a length of stay of 10 days or greater. In fact, I was just on with the OPWDD. We have a lady in our hospital who's been there for 290 days. They unfortunately live with us. And fortunately they do, meaning we can provide them with the basic needs that they require. So the plan is to really focus with the community members, this community, external agencies, to make a plan for those long length of stay patients. They shouldn't have to go to Albany Med if we can in fact work with the local nursing homes, skilled nursing facilities, other agencies that we work with. One of the current problems is there's not a robust coalition that works together. So in fact, tomorrow at 2 o'clock, I am starting a local coalition with the skilled nursing facility leaders, the administrators of those homes, to understand how we can move patients more seamlessly from the hospital to those areas. If we were able to reduce our length of stay, we would be around 35 inpatients, which, as I said earlier, is 25 beds plus 10 swing beds. We're going to be at or around that many patients. Now, I will say there are going to be upticks in patients when there's respiratory flu season, COVID season, whatever it might be. And we'll manage those patients because there's nowhere in the rule book that says you need to send patients away. If you can hold them and put them in observation status, they do that. And in fact, speaking to the CEOs of the other critical access hospitals, they say in no way, shape, or form does CMS say, you got to send that one patient home or send them some, okay? Today, I had this great conversation with PJ earlier. What we're doing today is exactly what we will be doing a year or 2 years from now. We will be transferring anybody that requires a higher level of care to Albany Med or any other hospital that provides those specialty services to those patients. It is important for us to continue to articulate that and state that because that is the right thing for any of you in the room. Because if it was me or my family member, I want a higher level of care when I require it. When a patient is critically ill, do you want them in an area that has, okay, Albany Med has 80 critical care units with somebody that staffs at 24 hours a day, surgeons, traumatologists, intensivists. You want care for your patients, your family, your friends, your family, period. I have to continue to say that, and I'm saying that to my staff, because over time, if you only have 2 or 4 ICU patients, you can't maintain your competency. And so when you calculate how many patients that equates to, those extra 10 patients or 15 patients we were talking about, it's about 240 annually. So that is less than 1 patient a day. So when folks say you're going to be transferring a bunch more patients to Albany Med, the answer is no, we're not. Possibly 1 extra patient a day, but most likely not, because if we get our length of stay to 4 days, and again, speaking to those CEOs of those hospitals, we know if we do it the right way and prove how we're providing care, we shouldn't have to transfer very many patients, except for those patients requiring a higher level of care. I think that was clear enough because that is one of the sticking points with everyone in the community, our employees. Our physicians understood it. Our physicians immediately said, our chief of surgery, our chief medical officer said, I've worked here for 16 years and my phone used to ring off the hook. My phone hardly rings anymore. So That means as a surgeon, she's not getting called to the hospital because patients aren't coming. Residents have decided to choose other hospitals over the years for whatever the reason. Residents have also decided not to come here because they need tertiary care. That's okay. I accept that. That's appropriate. We want patients to go to the right place for the right care at the right time. Hope I answered.
You did.
Okay,
I have one other question.
sure.
So I hear that you're doing no layoffs, which is great news. The total beds, 40 to 50 medical, now going down to 25 medical, 35 mental health, which is actually 60, which is a higher number of beds. So the current employees, are they going to have adequate certifications and training to go into the mental health side? Or will when you say no layoffs, like the total amount of employees are staying the same, but current employees need to be replaced with mental health providers?
Yeah, so we're not going to replace anybody. So when you look at an employee plan, first of all, because we have over 50% of our employees are bargaining unit employees, so we have to follow the collective bargaining unit, and we will do that. We're using currently 25 agency nurses and techs. The first people to leave are the agency. That's 25. Quite frankly, those extra 15 beds that we're talking about doesn't even require that number of employees. So that's number one. We are recruiting right now for our new mental health beds, those people who do have experience. And if anyone from the internal, just again, following the collective bargaining agreement, anyone who might want to leave med-surg and go work in general psychiatry because they have the medical background and they need the training in psychiatry will be trained by our education staff, and they'll go to coursework to do so, just like we do with any other department.
So layman's terms, new employees for the mental health side and decreasing the beds really is just getting rid of the agency contracted people that you're paying a lot extra to. And
That's right.
Employees.
Will remain. That's correct. That's correct. And to be very clear, the ICU staff will probably be reallocated to possibly med-surg. However, we may keep 2 ICU beds, and you still need to require that training because even the emergency room nurses, they need to be trained to stabilize people before they're shipped to any hospital. If it's Albany Med or anywhere else, we need to stabilize and support patients locally. So everyone requires that training. So when we think about it, we think about basic life support and advanced cardiac life support. All of our employees, it's mandatory that they get that training. So it doesn't matter which department you're working in. Yes, ma'am.
How are you?
Thank you.
One of the questions that have been brought to me by employees from the hospital are that their fear is that there is no plan to reduce staff from the system, from the hospital system, but they would be, if there was no place for them at Columbia Memorial, they would be offered Albany Med or Saratoga or Glens Falls or into another hospital, and that whoever is going across the river, it's pretty much already been decided because it's the ambulatory. So the ambulatory people would follow. So they would follow the route. Can you give any?
Yeah, absolutely. It's partially how I answered this question, but ultimately, if there are any employees that do not want to work in med-surg or geropsychiatry, they have every opportunity today to do what we would do in the future. So meaning all of our employees, today we have 116 postings. They can apply to any of those today. We also have a system which is always their opportunity. In fact, I have a number of ICU nurses that work at the Albany Medical Center ICU and work in our ICU. They have choices they can make. In terms of green medical arts, we have met with a number of people and will continue to do so. This is an evolution. We will offer them, if they'd like to work at Green Medical Arts in the operating room. Many of them, I think, would love it. And the reason is there's no on call as an operating room nurse. It would be open at 7 in the morning, closing at 7 p.m. There'll be areas like perioperative services, which means those are the recovery areas after surgery that many ICU nurses, in fact, work in recovery rooms after they work in ICUs. So Better, better, okay. It wasn't my fault. And, we'll continue to do that. I'd like to allay their fears. We wrote a letter to the union to explain some of these things, but I'm going to continue to have town hall meetings with our employees. And in fact, have one booked for the first week of December. And it's an open forum. Truthfully, we had them all last year and very little people attended. And I shared this plan earlier. I spoke about right-sizing the hospital, but I think once people heard it as we're actually applying now, that it became real to them, and I was extremely empathetic because our executive leadership team is empathetic. We feel it ourselves. This is a little gut-wrenching, but we have to do this. Because as I said to one group of, we had at least 80 or 100 employees in the room at the first town hall I had. I asked them, I said, would you like to close the doors of the hospital and just have an emergency room? Or would you like to have 25 beds and continue what we're doing? And just understand that there are about 15 patients a day that have these long length of stay. So the impact is not as big as people think it is. And it's math, but what folks don't understand is that we're doing the math every day and we're observing it every day. I think some of the employees think that we don't know what's happening because we're on whatever floor we're on. And we do. In fact, today, we were well above census because we're starting to see flu pick up and we're still caring for those patients. And there was something posted on social media, have Dorothy come to the hospital and see what we're doing. I was in the ICU today. The person who posted it was an ICU nurse, actually a tech. That kind of makes me chuckle because I don't think they recognize that we are fully aware of what's happening.
So there's no plan to reduce the staff and they will have choices.
That's correct. And they have choices today and we'll continue to do that. And in fact, we have a full employee plan. We have that today. Right? Because for example, sometimes we don't have any patients in the ICU. It's rare, but we'll have 2 patients, which requires 1 registered nurse and 1 tech. Where are the other nurses? Well, they go pick up shifts on other floors. It happens today. So we have to smooth it out. But again, I think, and I understand their feeling. I mean, it's a terrible feeling because you just don't know what's happening. But I also, change is hard. But I also need to reiterate, this is the right thing to do for the community, as Brian said, preserve services.
Thank you.
You're welcome. Thanks.
I'm curious to know whether you did a survey to find out whether the community really needed the mental health bed.
We did, yeah.
And how was that done? I mean, I think I'm a little surprised that was the need of this community. Maybe it is the region or something.
It's definitely both Columbia and Greene counties. There's going to be a 4% growth rate in mental health needs in our communities. That was a community services plan that was done, and so we looked at the region. This is all in. We also did a health equity impact assessment. We did surveys. It was interesting to me. The survey responses were in fact very positive. We met with our mental health partners in the community and the agencies. They were concerned about actually how do we place these patients post-hospitalization, post-acute care. My answer is, as it always is, we find a way, and we do because those patients are still coming to our emergency room, whether we have 20 beds, 30 beds, or 35 beds. And there is definitely a growth rate in that area.
The second question is, maybe to me, it seems like you're reducing things. So how do you reduce something and not reduce the staff? Maybe I just don't understand.
Yeah, because so
That's just how I see it, and maybe that.
it's hard to articulate if you don't work in a hospital, but here's the thing. Dorothy and Brian are in beds, and we're in beds for 200 days. There's 365 days in a year.
Right.
Those beds are full. Those beds are not turning over. So what I'm trying to say is when you have a length of stay, 15, 20, 25, 30, 40 days, 50 days, 100 days, we we aren't filling those beds, so we aren't turning them over. So that means we're not seeing increased patients through the door. We're just managing as patients. And that's what I said earlier. I need to manage as patients better. We know we have opportunities there. In fact, when I was on, we did a number of calls, focus calls, and I did it with Senator Hinchey, and she didn't understand the issue either. And she was struggling with it a bit. And it was interesting to me because when we try to articulate it, she said she spent 5 hours with the local nursing homes and they don't have any beds. And then I had a focus group with the local nursing homes and I asked the blatant question, do you have capacity? And they said, yeah, we have capacity. Please send your patients. I said, where's the disconnect? What are we doing wrong? So that's the coalition I'd like to start, starting it tomorrow. And we're going to be working with them to say, how do we do better? How do we get our patients into a skilled nursing home or in an external agency in an improved fashion? That case management has to happen better. And it's not happen tomorrow. Because over time, we're going to essentially improve what we're doing from a clinical and operational perspective. So that when we get to the point of, 35 beds, then we're ready to convert to a critical access hospital.
Yeah, we got up to 100 beds.
That's where the sweet spot is in a hospital. We have to fill our hospital to 100 patients every day to be able to. I don't know if this is. Hello? I think it's dead. Something's dead back there. I'll just scream.
To have 100 patients in the hospital is sort of our sweet spot in terms of being able to pay the bills. That's the bottom line. So it's either 100 or it's 25, and the reimbursement changes for us. I'm going to just share a story. CEOs in the old days applied for hospital designations, received hospital designations, and the community didn't even know about it. Why, you ask? During the pandemic, hospitals in New York City and across New York State decided to close units, close beds, because they didn't have enough staff to care for the COVID patients. Nursing homes did the same. It was the reality of the horrible situation that we were in healthcare. We didn't have enough staff. We didn't have enough beds. They were closing units. They were closing surgery units. They were closing. New York State Department of Health in 2021 came out and said, you must complete a health equity impact assessment moving forward. You must complete a closure plan moving forward. So we understand better why you're doing this at your hospital. So now it's out there, which I'm actually happy about. I'm happy to stand here and provide you this information because you then can articulate it to your constituents. But that was a mandate. And so that changed. But for years, so do you know what Columbia Memorial Health is? What our designation is today? Anybody? We are a rural referral hospital. That is a CMS designation that tells Brian Mahoney as the Chief Financial Officer how we're being reimbursed every day for those beds. Other hospitals are community hospitals, sole community hospitals. And then there's critical access hospitals. The CEOs in the past used to just do this. This was a back office function. Now we're out there. We're letting you all know. Yes, sir.
So firstly, thank you, and I appreciate your honesty on this whole situation. Let's assume positively that the designation will happen, but you did say 6 months to 2 years. If this is a prolonged experience that it goes to 2 years, what's the interim plan?
Yeah.
Because looking at those numbers are pretty daunting. And
They're terrible. They're terrible.
and I realize that you want this to happen as quickly as possible.
We do.
But what happens if it's extended?
So you're asking really about what happens with the finances. We're going to continue doing what we're doing. At our community town hall, we had Dr. McKenna, who was our Chief Executive Officer of the Albany Med Health System. He said he was committed. I needed to hear him say that as well, but he is committed to us. They have been, quite frankly, providing financial support on a monthly basis to us right now. They will continue to do that. But
We also have applied to New York State Department of Health Safety Net Grant. We have requested $20 million to support us and bridge the financial gap until we get to critical access hospitals. Crossing my fingers, we've been responding to a number of questions from the state. And I'm hopeful that if we receive those dollars, that again, that will carry us through until we get to where we need to be. Yes, sir.
I'll just offer quietly for context that a third of the hospitals in New York State are in a program with the state and have been for the last 2 to 6 years, where the state essentially funds their payroll. And they're at $0 cash. They collect money every day. They get to this point, payroll comes, it's meant to dip, a wire transfer comes in from the state. I'm in contact with several other CFOs that are in that program. They say it's not great. We don't know if money's coming or not. We're trying to avoid that at all costs with our partnership with Albany Med. I'd be remiss if I said we didn't walk into the state every 3 to 6 months and say, this is what's happening, this is what's happening, this is what's happening. We're preparing you for the potential. You might see an application from us for this program. And one of the things they said to us when we were in the room where we had, I want to say, 35 or 40 days cash and one, not counting the reserve funds. So here's where we are, it's going down. And they said, you'd have to put a decimal point between those numbers before we're willing to step in. So that's what we deal with some of these statewide programs, but we have pursued every single one of them that has come up over the years and will continue to do so. And the partnership with Albany Med has really been sort of a lifeline for us over the last 2 or 3 years, making us thankful we affiliated when we did. One of the CFOs I'm in contact with is an independent community hospital out in Western New York, and some of the stories he shared with me are scary.
Yes, sir.
Thanks. Michael Shemidas. I represent the district that includes the hospital. So I'm really thankful that you're here. This is a lot of good information. I think we all really want the hospital to be successful, and we all also really care about the employees and the healthcare workers at the hospital. So this is a big issue for us. I also just wanted to give some context of what I've experienced is this real fear about the hospital. You know, I think it really kicked off when the birthing center closed, and just feeling that was like, that's a pretty big loss for our community. But I think it also symbolically was this fear, like what is coming next? I think over the last few years, like since the pandemic, I've heard a lot of concerns from the employees at the hospital about how hard it's been and how like they felt like they've been understaffed or overworked. It's just been a very difficult time. And so I think that added to this sense of pressure for the hospital. And then I've certainly talked to a lot of like prospective patients who say it's hard to book appointments because you can't get in, or and so I think that's a really difficult time. So I think like that adds to this context. Then the big beautiful bill happened. We passed a resolution opposing those cuts to healthcare because we know that rural hospitals around the country are going to suffer from this. So I think there's just a lot of fear right now about healthcare. We really want you to succeed. So I think when this announcement came, it came at a time when we're all really worried about things. It's unfortunate that there was some misinformation about what that announcement really means. And so at the same time, I think I want, and maybe some of us want as well, is also like this honest conversation about how things are challenging. So you may need to make a shift from 100 beds to 25 beds, but that also maybe, I think people are worried that is a cut from like the birthing center, this is just the next thing that's going to drop. And is this really a system model for the hospital, or is this just the next cut that we're going to see? And so I appreciate the sort of like real talk that things are really challenging. I think this question around like the math, the math is still confusing. And so so I believe that things are really challenging. You have to make tough decisions, but I think when you describe this move to 25 beds, like it's not totally convincing if this makes sense or like if this is going to work. So I guess I just wanted to share that context, and I think whatever I can do, whatever the board can do to make sure that the hospital is successful, we want to do it.
So first of all, thank you. And number one, I feel the same way you do, and every constituent in this room. I lose sleep every single night. My job is to make sure I'm able to pay our employees. Brian and I worry about payroll every week. So that's number one, and I think the employees need to understand that as well. This is not fear-mongering. I agree with you. And this is a national issue. I'm just going to take a few of the things that you've said and put them into compartments. Number one, I want to talk about the Berkeley Center for a second because I want you all to understand something called volume outcome procedures. When you are in a hospital, you do not want to go to a hospital and birth your child when you do 300 births a year. What does that mean to you? It means less than one birth a day. Are your nurses competent? Are your obstetricians competent? And I will tell you, no, there is no way in the world. And do you have a level 3 NICU? No. So you do not want to go and have a baby at a place where it's shrunk, because our outside demographics is a negative 2% growth rate here in Hudson County, in Columbia County. So we're not growing. We don't have young people, we have elderly, and we're aging. So that's number one. So I just wanted to put that into a compartment. And I really want you to know that as a clinician myself, I will never do the wrong thing at the hospital, meaning any procedures we shouldn't be doing there, we shouldn't be doing there. I will never have morbidity or mortality on my hands. Okay, that's number one. Number two, it's not 100 beds, it's 45 beds to 25. That's a big difference. So the newspapers aren't always right. But we need to be clear, 45 beds to 25 to preserve community services is a big deal to us. And it's not the next cut. And I was very clear with the employees that this is it. And once we become a critical access hospital, it is the best thing to become, because we will have money. We will be able to reimburse ourselves. And that's why I said reinvest in ourselves. And that's why I said, speaking to other CEOs in the communities, they really articulated that. They were in the same place we were. Number three, he knows that I'm an extremely empathetic leader. And quite frankly, I was tearful telling the stories of this family because I could see their faces and I felt horrible. But who's better than me to present that story? I've been here before. Here in the office, here, I have been in this room, but here in this place, in this situation. And it's time. And I'm extremely passionate, as is my executive team and my board, to make the right things happen for the community. So I agree with you. It's hard. But either we're going to fight it, or I'm going to sit down on my laurels and do nothing. And then you'll have nothing here. So I'm sorry for the negative information. It comes out that way. But again, we're sharing it. And this is what we're doing today. And I'm happy to come back here. If this gentleman invites me back every month, I'm happy to come back and give an update. I am really happy to. This is the right thing to do. Thank you. Thank you for your comments.
Any other questions?
I'm grateful for all of you and all of your service and listening to us this evening, and your support. And I am asking for your support out there in the community. And if you want to give them my number, please do, because I'm happy to speak to people. And in fact, when that letter came out, I was on the phone for 3 days straight, night and day, telling my story. And I think people are starting to get it. Thank you.
Thank you.
Thank you.
Okay, Supervisor Collins, Health and Human Services.
Sure, I'd like to call this special Health and Human Services Committee meeting to order. We're gonna start with resolution 358 of 2025, authorization to approve a contract with the Greater Hudson Promise neighborhood.
Move it. Second.
Further discussion? All in favor?
Aye.
Opposed? Carried. Motion to adjourn.
Motion to adjourn.
Second?
Second.
Further discussion? All in favor?
Aye.
Good night, everybody.
Supervisor Lagonia.
Yeah, I'd like to call a special public safety committee.
Well, you're really messing up tonight.
Put up the flag and I'll go.
You go ahead.
Okay, I'd like to call the special public safety committee meeting to order, please. Resolution number 359. All in favor? Opposed? So carried. And resolution number 360. Yes.
Second.
Sure.
Before we go. So I think I understand the reasoning behind this and agree that it's a great thing. There's a lot of vagueness in the resolution as it's typed. Doesn't list which towns, kind of gives blanket authority to enter into contracts with all towns, it seems. But my two bigger concerns and what I'd like to see potentially built in is clarifying that it's a one-year contract, because this is a new thing and there's nowhere in the resolution or the contract that defines that it's only.
Yeah, I understand that was just a sample contract that was written up by this H&H Consulting.
Yeah.
That falls as a sample that is yet to be reviewed by wherever you want. Rob, there he is.
Yeah.
Yet to be reviewed by him.
Okay.
So yes, it is a one-year contract and it's strictly basically for the towns in the southern part of the county,
Yeah.
as Empress won't be servicing that area.
Yeah.
And it's the other, the question that came up was, is it going to be budget neutral? And the answer is yes. The towns are being asked to fund no more than they did in 25.
So I would like to see those two things built into the resolution, because correct me if I'm wrong, but the way it's written right now, it should be the board that sets it. It's a one-year contract, not your review of it. And because the contract is just a template contract, I think the resolution should state that it's a one-year contract.
That's fine.
And also I would love for it to state that it's budget neutral. For example, since we've never done this before, if the town of Gallatin pays $100,000 for 25 or 26, I'm sorry, and come the end of 26, we realize that it actually costs the county $110,000 to provide that service, then they would have to build that into their 27 budget,
That's
the
correct.
extra 10,000.
This will be reviewed, obviously, when we get towards the end of losing track 26, yes, to see what the costs are.
So can
And
we just,
hopefully by that point in time, we will have a countywide financial system in place, so that's kind of the goal.
Yep.
But in the meantime, I can't control on what towns have allocated for 26.
Right.
So some towns have already indicated to me, well, they're 3% increase, so it may not be exactly the same as it was in 25, so
Yeah.
I don't know how you word that.
so I think, and I defer to Rob, but if the committee was amenable, that we could build right into the resolution in the resolved language that these contracts are for no more than 12 months, and that the cost to the town, the county is budget neutral, and that the towns pay at least what it costs the county to run.
No, I disagree. Because we're signing a contract with Columbia Memorial right here, the county, for X amount of dollars, which is stipulated in our contract for 26. So their squads are saying that, yes, in my towns, in our towns, in the southern part, are gonna do this for X amount of dollars for that year. If it costs them more, it costs them more. They're making that deal. I'm not gonna be responsible if they come up with another $40,000 at the end of the year. So my contract, the way it's written, which I believe in my contract does say 1 year. actually, it is already written on that, the specific amount of money. So when I sign that, I'm not signing onto it and then wind up with a bill at $50,000 at the end of the year.
But it's not the county.
In 27, when we go through, the EMS is going through right now to committee to look at this and try to get a better disbursement, through the whole county. That's fine. When I sign on to that, I'm fine with it, but I'm not signing on to no open contract like this. I disagree with that.
So
Let
that
me
question
just-
was, I asked that exact
Let
question
me just
you're asking.
clarify that.
So if there is a deficit, because I asked the question, because they're gonna be taking those contracts on with existing.
Transferring.
Yeah, exactly. I said, who's gonna eat the difference if there is a difference? The squads are.
Okay, so it's not the county.
No.
Correct. I asked that specific question. It's not the
Yeah,
county,
we
it's the
discussed
squads.
that.
Because
Okay.
again, to me, they're going into this a little bit blind.
Right.
We had a budget process.
Right.
This is not. They've looked at these numbers, they've looked at
So
the
the
area.
squad is contracted with
Correct.
the town.
Right. Correct, because I wanted to make sure that the county, if there was a deficit, was not footing the difference.
So can we put in the resolution that the county will not pay anything for these contracts to take place?
Can I offer some language?
Yeah.
Something, so maybe the attorney can help us, but something like after the first resolve, the second resolve could be resolved, the county is not committing to provide services to the towns above that cost more than the reimbursement from the towns to the county.
I don't know, in my contract, it says a specific amount of money that they're gonna do for me for 1 year. It's very, very clear, very simple. I don't think it needs anything.
Right, so I
other
guess
than
what, I
This
guess
is
what
where it is.
I think the intention is that I'm hesitant to sign off that the county on this vague language, that the county would basically incur a bunch of costs for a contract that I've never seen. So I guess that's the protection that I'm trying to get to, is to be like, what
Because
is?
you're on that committee.
What's that?
You sit on the committee, right?
Yes.
Yeah.
But I think the difference is that like my town contract with Chatham Rescue Squad, we're not asking for this contract with the county and New Lebanon. So that's where we want the language protecting the county.
Okay.
Because I contract directly with Chatham Rescue. This is saying we want the contract with the county with your
That's
town.
fine, as long as it's not coming back to the county.
Well, if your contract with the provider says it's going to them, great. I just want
My
language in
contract
here
is
that
actually-
it's not the
excuse me,
county.
Can I just clarify?
Yeah.
Okay, this is a very simple situation. The town of Livingston, let's say they pay $100,000 a year in their EMS chargeback. And traditionally, they contracted directly with NDP. In this particular instance, they are now going to contract with CCEMS, who has the operating certificate for the whole county. CCEMS is then going to turn around and contract with Greenport and Copay and give them that $100,000 according to who's ever servicing Livingston or whatever town. There's no additional cost to the county whatsoever. Nothing has changed since last year, other than who they're contracting with.
So what's the harm in putting the language in the resolution stating exactly what you just said?
I have
That's
no
the part I'm
problem.
not understanding.
Are you gonna see more standby times if these current ambulance services are heading south? Where some of the northern ambulance services are gonna have to come down and do standby in their territory?
No, hopefully this number of standbys will decrease because I gave an instance for 2024. Community Rescue Squad went over and stood by for NDP 599 times. Okay. Greenport went down 300 and some times. So if Greenport and community are already servicing that area, there should be less standbys from the northern part of the county, and they should mostly be taking care of themselves. So I'm looking at hopefully a decrease in the operational expense.
Rob, since we don't have a contract in front of us, and since we have this resolution, I think it's reasonable to add what they're looking for. I had the same concern.
No problem.
So we can add that in, and that's what we would agree upon.
As amended.
As long as we understand that the towns,
That's
There are
my
no
concern. I
future,
don't want it to come back.
budgetary, expenses,
Correct.
right? So however you want to word
Could
that.
I offer moving the resolution with the attorney to amend to include a one-year contract and that it will not cost the county anything? And you can build it whatever word you can.
I would go along with that.
I'm fine with that.
Okay, so I'll move it.
Everybody Okay. All right, so do I have a motion?
I'll move it.
I'll second.
Second, all in favor? Aye, opposed? So carried. Motion
Thank
to
you.
adjourn?
Motion.
Second, all in favor? Aye. Thank you, everyone.
Next is Special Economic Development, Supervisor Skoda.
Once Kelly's ready.
Yeah.
Good evening, everybody. I'd like to
So
welcome
thoughtful of you, Supervisor.
Economic Development Committee special meeting. We have Resolution 361, authorization to submit an application to the New York State Housing Trust Fund as part of the New York State Office of Community Renewal for the Pro Housing Technical Assistant Grant Program.
I'm happy to move that, but if anybody would like, Chris is here, if you would like to explain that to us, Chris, anymore, then give everybody understand what we're doing. This is kind of new, so.
I can still do it. Yeah, so this is, the county would be the lead applicant on this because we confirmed with the Department of Homes and Community Renewal that if you have a jurisdiction where multiple component jurisdictions are all pro housing certified, the county can be the lead applicant if it gets letters of support from each of those municipalities. And should I say it tonight, Mike? Should I look the cat out of the bag? So I think everyone knows every single community in Columbia County is now pro housing certified. On the website, our map is the only county colored one color because we're all certified. So previously, last year, we had applied for a community development block grant under their community planning program to do a countywide survey of existing conditions of buildings throughout the county. It was really competitive last year. We didn't get it. Now there's $250,000 available through this Pro Housing Technical Assistance Grant Program. So we can not only go back and have a much more competitive application, applying for a bigger pot of money. Now we'll be able to do a true countywide survey of building conditions, but we'll also be able to get some legal advice about how to track down the owners of some of the most abandoned properties. What are some legislative changes you can make locally? Basically, we're trying to figure out how to get buildings online that are already there, because that's the lowest hanging fruit in rural development. You don't need new infrastructure. What we do need is a pipeline of properties that are vacant, abandoned, and distressed. Then figure out which programs to get those into, and then we can apply for programs appropriately going forward. That is the application that will be going in. It is due November 25th, and I sent a template letter of support
to everyone except for the village mayors, who I will get tomorrow if this goes well tonight.
Send one back to you, but don't look at me as a competitor, all right?
Okay, oh, yes,
How does it apply to?
that's a really important point. So if there are any towns or villages that also want to submit their own application for this same grant, you can do that. That was the second point that we confirmed with the state. Yes, and we'll help craft those applications. Supervisor?
You said you're gonna include all communities that are interested submitting our letter of support. Is that us saying we're interested, or do we need to do something else?
Nope, that's all. So it's just like, it's similar to the +1 program. We got letters of support from pretty much all the participating communities, well, all the participating communities. So it's the same thing. I'll poke you again, hopefully only one more time.
Okay.
And necessarily will create letterhead and grab the letter.
I already handed him my letter. I just want to
Yeah,
make
I've
sure.
got a few.
I get on the list.
So I'll second the motion.
All those in favor?
Aye.
Any opposed? Motion to adjourn.
Motion to adjourn.
Second.
Second.
All those in favor?
Aye.
Any opposed? Thank you.
Thank you. Thank you, Mike and Chris.
Thank you.
So next is, special finance supervisor Dudley.
You ready, Kelly?
Okay. He's flying souls.
I know. Okay.
Yeah.
All right. I'd like to call the Special Finance Committee meeting to order. Resolution number 3582025, authorization to approve a contract with Greater Hudson
Move it.
Thomas.
Second.
Have a motion and a second, all in favor?
Aye.
Opposed? Carried. Resolution number 3592025.
Second.
We have a motion and a second, all in favor?
Aye.
Opposed? Carried. Resolution number 3602025.
Second.
We have a motion with a second.
Yep.
Motion and a second, all in favor?
Aye.
Opposed? Carried. Resolution number 3612025.
Second.
Motion and a second, all in favor?
Aye.
Opposed? Carried. Resolution number 3622025.
Move it.
We have a motion and a second, all in favor?
Aye.
Opposed? Carried. Resolution number 3632025.
Second.
We have a motion and a second, all in favor?
Aye.
Opposed? Carried. Motion to adjourn?
So moved.
Second.
Motion to second, all in favor?
Aye.
Thank you.
Thank you. Well, the full board meeting to order. Please rise for silent prayer followed by the speech of the flag. I pledge allegiance to the flag of the United States of America, and to the republic which stands one nation under God, indivisible, with liberty and justice for all. I request the clerk call the roll.
MacArthur.
I am here tonight and one more time.
Two more. And
Two.
You can wait that easy.
Weigel.
Here.
Holmes.
Here.
Simmons. Sacks.
Here.
Wolf.
Here.
Hans.
Here.
Riley. Eldridge. Helsley.
Here.
Borchert.
Here.
Livonia.
Here.
Martin. Mia. Chemidas.
Here.
Musman.
Here.
Scalera.
Here.
Bezzy.
Here.
Colton. Here. Morale.
Here.
Not.
Here.
Dakota.
Present.
150.4, present, 49.6 absent. We do have a quorum.
Thank you. I need a motion to pay the bills, accept the president's report, and file the minutes within the clerk's office.
I'll move.
Second motion.
All in favor?
Aye.
Those carried. We request the clerk to get resolutions. Ready?
Resolution 337 of 2025 through 349 of 2025 by Supervisor Not.
Mr. Chairman, I offer these resolutions for adoption.
Second motion.
All in favor?
Aye.
Opposed? Carried.
Resolution 350 of 2025 through 363 of 2025 by Supervisor Skoda.
Mr. Chairman, I offer these resolutions for adoption.
I second the motion.
All in favor?
Aye.
Opposed? Carried. Any supervisors have any other business to bring to the board? With that, I want to wish everybody a happy Thanksgiving.
You as well. Thank you,
And
Chairman.
I'll entertain a motion to adjourn.
So moved.
All in favor?
Aye.
Carried. Everybody.